And so this is a public meeting and the recording is about to start according to my screen. Declaration of interest of and any hospitality or gifts. Anybody like to declare?
No.
Nothing out of the ordinary, thank you. So going straight on to minutes of the previous meeting, that's 24th of February. Are we happy to accept those as a clear, accurate record?
Yes.
Yep, thank you, Joe, very much for those. And on the action log, just waiting for my screen. So the first action is 2043. That was in response to questions from the public 100-day challenge, and we know that a reply is being constructed that will come summarising the emails that were flying backwards and forwards as an update on those. So we anticipate those soon. 2054 primary care estates overview. That's on the agenda today, and I think we cover most things. Is Julia here to present or not yet? Okay. 2106 is closure of the Christmas maltings, and this was consideration of bus routes. Stuart, I believe you were going away to ask a question on whether there's any change or any update.
Yes, I did, and I do apologise. I should have sent something for Joe to put in the action log previously, because I did go back quite a while ago. Yeah, so I contacted the GP Federation who manage the Unity Healthcare contract. They in turn have been in touch with the bus company, and it transpires there are quite a few bus routes that already have a stop outside the Clement surgery. So I think, you know, in terms of access to that surgery, there are buses that already stop there.
Okay, lovely. Thank you for the update. So we'll include those and then we can close that action. Thank you. So item number 5 is general update. Lois, I believe we come to you.
Right, I didn't know that Kate wasn't here, so I'm not sure what the general update will be. Suffice to say that general practice is very much focused on business as usual and getting back to that. And in the performance report, I'll be able to show you a nice example of how we are seeing that trend go upwards. And obviously the other massive ticket item is the vaccinations. And that work is obviously ongoing. The GPs are focusing on finishing or continuing to do their second doses. But again, that's very much covered off in the paper that's coming on later. So in terms of updates, really those big ticket items I think are being handled further along in the agenda.
Lovely, Lois. Thank you very much. Well, we'll leave it at that and come to your paper later on. Thank you. So item number 6 then is the primary care contract performance report.
Brilliant. Thank you. So yeah, so it very much, well, it doesn't completely follow what is it is you'd normally expect. So as you remember, Emma is seconded out to do the vaccinations, and she's doing that 100% of the time. So it's left for me to try to work out what she was doing in creating these reports. But it gave me a handy reminder of what I used to do. So that's all very useful. And also let me have a little sort of a review of what we are putting in there and add some more detail for this time. So number 1, the prescribing budget, you know, that is, you know, it's not really a performance, it's more of a statement of fact. Obviously, we've got challenges, you know, during COVID, lots of different things happening around the budget, including GPs, you know, prescribing 3 months worth of drugs, which has led to peculiar patterns, as well as a general increase in some very expensive antidepressants. So the medicines management team very much have a handle on the why, and beginning of this month, the technicians are beginning to go back into practices. So one of the technicians has worked all the way through COVID and has gone into the practices and hasn't ever been remote, and that has been her choice. But interestingly, that particular practice shows a 13% difference positively in savings compared to 23 practices that didn't have that absolute support. So where we are now with the team is, obviously, if people are shielding or they feel uncomfortable or the practice can't accommodate them with proper social distancing or in a room on their own, the technicians are remaining, working from home. But where it is possible, they are doing a hybrid of working from home and working with the GPs, because what's missing is that clinical conversation. If you just send somebody a task list, it just ends up in a task list, I imagine. But if you're able to have a conversation around, the rationale and everything, it seems to land much better. So we are moving back into that territory. Obviously, that's just one example, and that's not, statistically relevant, but it was just very interesting.
Yeah.
So in terms of the severe mental illness health checks, they're working, and we've said before, there has been a reluctance of people to come into practice, which we're beginning to see reverse now. And also the NSFT physical health team have been working really well alongside primary care, picking up people early when they don't respond. And that's something that we're trying to also replicate with the LD health checks. So have a very early pickup of people who are non-responding. The other thing we're trying to do with primary care is get the work spread more evenly across the 4 quarters rather than more back-ended, because that would give the teams the chance to really get to grips with them. I'm trying to champion the idea, so there's several different new and slightly conflicting bits of guidance that we'd need to adhere to. There's a big push on the fact that people with an LD often don't attend statutory screening, so breast screening or bowel cancer or the like. So there's that piece of work. There's also obviously the annual health check to be completed, bit of work, and so I'm trying to encourage the LD nurses. We've got 1,700 people at the moment on our list in West Suffolk to actually hold a physical list per practice, so that they would know with fingertip control who is not responding, why aren't they responding, and also if they have had a health check but are not going for cervical screening or breast screening, and to be able to have much more of a case-by-case control over the cohort, leading them then to have care plans for how to encourage uptake of 100% of all of the health offers. Interestingly, so we've just come from a meeting around screening targets for LD. The government has now changed the policy on LD and autism, and is pretty much adding autism in with LD, which is going to see every policy change as they get to grips with that new agenda. But the conclusion that they reached regionally is that they can't send letters which they can't see who does need to have a letter that might be more simply put, because they can't see the read codes. So my pushback was, well, why doesn't everybody get a letter that everybody can understand? Because that would not only help people with a learning disability or a reading difficulty or English not as their third language. So it seems ridiculous that we're trying to run 2 sets of communications when actually everybody could understand a more simplified version. So they've gone away to go and push that up to the national team, because obviously these are all national must-dos. But on the whole, I don't think we've got up-to-date figures. By the time I'd written this, we haven't had up-to-date figures for LDs. It's something that the practices have to add onto a website, and I've got about 4 practices that haven't done it yet. So when that comes through, we can send that as an addendum if necessary. Dementia, obviously everybody is in a similar situation in that a lot of the people that we've sadly lost to COVID have also, been in a care home or care setting and had, dementia as well. But equally, we know that a lot of people, again, through COVID isolation, either in their own home or in a care home, has led to an accelerated position in terms of dementia. So the GPs are doing ward rounds either virtually or physically, dependent on the home and the situation. And so we think in a few months they will be starting to pick up these poor people who've, due to not being able to have relations, come in, have obviously lost a lot of ground in terms of, their memories, which is, of course, incredibly sad and another, terrible outcome of the pandemic. Flu vaccinations is a whole appendix, but the good news is there was a massive uptick in people wanting the flu, I guess for myriad reasons, but that has seen a very positive effect on pretty much all the different cohorts. And for those who want the granular detail, it is on that last appendix. And then, but the bit that I was going to draw your attention to is cervical screening data at item 7. So this shows by practice what they had done on January, February, March. So it's every, I think, 2 weeks. And I think it mostly, not entirely, but I think it mostly shows you how practices are, we're ramping up back to sort of business as usual. Certainly the first one, Unity, is a reasonable jump. Some have gone down, but to be honest, they also are, it does depend on if they've always been good and been on top of it, they wouldn't necessarily show a big uptick. So that is about all that I would want to say about that particular
Thank you.
paper.
Thank you, Lois. Any questions for Lois? No. Well, I'd like to just ask, I see that 12 of the GP practices have signed up to the ES relating to COVID and the LD annual health checks. What happened to the other 12, and are they evenly spread around the PCNs? And do you think that makes a difference or not?
So no, they all are doing the LD leses. There was the ability to do 2 other things. One was if you get more than 67%, there would be an extra payment. But I think the one that you're talking about is the one where if they were to do the health check and a COVID vaccination, there would also be a premium. So some of the practices weren't, because mostly the local vaccination sites were PCM based, not every practice has taken AZ back into their practice. So obviously they wouldn't have been in a position to do it at the same time.
That's fine. Okay.
And also it does depend on supply. So,
yeah.
And also if you break a vial, you've then got to use a vial.
Yeah.
So it wasn't the most practical incentive scheme. And only those that knew they could deliver it without wasting took it on.
Okay, no, that explains that. Thank you. And I was just wondering, there's a slot around the dementia talking about the memory assessment, but also the memory impaired diagnosis or
mild cognitive.
And I was just wondering, it talks about advertising of the Sue Ryder Dementia Together and the pre and post diagnosis support. And I just wonder whether that, as people are coming out of lockdown and getting are out and about more, that there might be more cause to communicate that to the public again and to encourage them to let localities know, and even down to local authorities perhaps in their newsletters, that there is such a service that they could refer themselves to, and then then be helped along that journey, especially as what, I just wonder, I think it's an opportune time.
We have sent it out last week to practices, and with the hope that they'll share it with their PPGs, but there's no harm in taking an action to make sure. I mean, to be fair, Gail Cardy, and there is a team of people working on dementia, they probably have done it, but it will do no harm in checking, where it's gone and making sure, as you say, that offer, no matter what your definitive diagnosis is, that offer of support is there. So I don't think it'll do any harm, as you say, to make sure it's gone far and wide.
Yeah. Okay. Thank you very much. Okay. Any other questions for Lois on this paper that we're noting? No. Okay. Thank you, Lois, very much. Very. I
think it's me next as well.
Pardon?
So I think it's me next as well. I think it's the me show.
Over to you then. COVID update number 7.
So basically, you had a paper before that set out what the GPs had done in response to COVID last year. So we had written a paper that took you all the way up to when we started vaccinating, basically. So it described the various things that they'd done in terms of the Fed visiting car, how they'd organised hot and cold areas or surgeries, how the PCNs are pulling together. So this is really to sort of pick up, what happened next, the next chapter, if you will, and that is to cover off, how the vaccinations have been getting along, how they've been developed, and kind of the rationale behind it. So when the vaccine first started, PCNs were told they can only have one site, so it would only be 6 sites that are operated by GPs in West Suffolk, and each site had to have a comprehensive assessment in order to ensure that they, as much as possible, you would guard against wastage of Pfizer. And I'm sure everybody knows now that Pfizer comes in it has a shelf life of 120 hours, out of the freezer, and therefore its delivery to the practice and then its delivery into the arm is time limited and very sensitive, and has caused a lot of angst at times. But each of the PCN nominated sites has been accredited and have been delivering Pfizer vaccinations ever since. We are still at the point where practices cannot call down their own vaccinations, which is a shame. We still are subject to NHS England telling us what we're having and when. And an example of that is last weekend they basically the Swan surgery had to deliver a tray of Pfizer and what they call a baby tray of Pfizer that NHS England had delivered on the same day, which put the practice under significant pressure. Had they refused the baby Pfizer, they would have missed out on a whole load of second doses for patients. And NHS England were not able to guarantee, if they did refuse it, when they would be able to get it back. So you wouldn't have been able to tell the patients when they would have their second dose. So the Berry 5 took the difficult decision to try to make sure that it worked, and basically had people queuing, I don't know if you know this one, right out onto Northgate Street. So patients waited in order to try and quicken it up to get it done within the 120 hours, which they did with no wastage. It got down to the decision was whether it was going to be sunny or not, because they hadn't got room in the tents to keep people in. So they managed it. They definitely don't want to do it ever again. It was not ideal, and the system was under a lot of pressure, but they achieved it, which is they are to be congratulated for that.
Yeah.
As you can see in the grid 1.1, very high. Obviously, sorry, I should say in parenthesis, they are not the only people vaccinating, and we cannot differentiate between what they've done and what others have done. So West Suffolk Hospital started off vaccinating just the week before the GP started. They were stood down several weeks ago in order them to be able to redouble their efforts into business as usual. And then we got a mass vaccination site in Bury at the Riverwalk School open up. And we've got Pharmacy to You are working out of Newmarket Racecourse. And we've now got vac sites, which are not open all the time, in Mildenhall and in Haverhill. So these figures are in the round, so I'm not claiming them all for primary care, though they definitely did a lot of them. So as you can see, very high numbers of the cohorts that we've been able to tackle. So I think you all know about the big weekends. Both Bury and Blackburn have done significant work, and I think this last weekend was the rerun of the Woolpit drive-through that they did in the snow. So they at least had kinder weather this week, which was nice. The challenges I think we've spoken about. The supply of vaccine has been hit by all sorts of different conflicting issues, including Brexit and all sorts of other issues which NHSE is tackling on the national arena in order to try and get surety of supply. Obviously now we have some of the patients are becoming concerned about AZ, and people are asking for specific vaccines, which is causing some problems as well for primary care. So at the moment this week, primary care is just doing second doses. They haven't got extra vaccine to start doing more first doses. So basically that situation will right itself, I think, on the week of the 16th of May. So at that point, primary care will have discharged the second doses, and they will be able to get on with starting on the first doses again. And that's about it, really, unless you have any questions.
Thank you, Lois. Jeff?
Paragraph 1.4, Lois. What's this phase 2 and some practices not wanting to roll over? Can you just explain that one to me, please?
So the initial ES took you from cohorts 1 to 9, which is basically 50 and above. And then obviously there's some more cohorts in there that muddle that, including carers and frontline staff, but basically. So these are the biggest cohorts, and these are the ones which there's been the most concern, the most vulnerable, either through exposure or through age or through health disposition. The government then had offered a second ES to primary care to carry on working down the cohorts, but it was very much on the backdrop of you need to make sure that business as usual is in place. So systems have reacted differently. So Forest, Heath, were 8 practices. They've got a very slick system, and they were very happy to continue. But for lots of reasons, a mass vac site was put into Mildenhall, and that meant that they would be competing for customers, and they just didn't need the extra hassle, really, because they were delivering nicely, use it from Newmarket, and then the Newmarket mass vac site came on board, and what happened was they were both scrabbling around for patients to fill clinics. And when you've got Pfizer, it doesn't matter, Pharmacy to You using AZ, if they don't fill a clinic, they just shut the fridge door. But if primary care doesn't fill a clinic with Pfizer, then we get into wastage. And so they felt it was too difficult to fill Pfizer clinics with lots of competition in the back garden. So a lot of them pulled out for that reason. Bury stayed in and Blackburn stayed in. Haverhill, the Federation always said they were only going to do the first phase, which they've done, and now there's a mass vac site in Haverhill that will pick up the slack there. And Sudbury have chosen not to continue, and they are now trying to sort out some vaccination alternatives for the people of Sudbury. So yes, there will be coverage for everybody in time. And to be honest, we have got a hiatus in supply at the moment. So actually, it's giving us some breathing space to sort out, what we need to do to get the next group of people through the door.
Thank you, Lois. And Stuart.
Sorry, yes, hello. Lois, can I just ask you, the vaccination figures in the report, I mean, they're brilliant in terms of being, almost near to 100% in some cases, but obviously they're not 100%. So I'm just wondering, now the vaccination program is 3-4 months down the line, especially for the, the over 80, 70, the elder age group who are more vulnerable. Have you or will you be doing any kind of analysis on what the gap is, why there is a gap, who it is that's not coming forward and why they're not coming forward?
Yeah, there's been a lot of work being done, both in terms of absolutes and also in terms of health inequalities, different barriers to access, to see if we're just not communicating effectively. And as soon as the codes are made available, the GPs were coding, why are you saying no? In the early doors, some people were waiting for AZ because they didn't like the sound of Pfizer. But those have mostly stepped forward now. So there is a constant kind of on loop checking. We've got a lot of people who we think are living abroad, either by choice or by being stranded. Definitely, is a problem, not massive, but these are very small explanations which add to the quantum, where they haven't been able to get hold of them at all, using any means. But yes, so there is a lot of analysis done on this group, and obviously some people don't believe in being vaccinated, and that is recorded, and then they are left alone. And there is a conversation about whether you should go back around and ask one more time when somebody has empirically said they don't believe in vaccinations. And I think we're still sort of scratching our heads about what point are you pestering somebody and what point are you not allowing them to have their opinion.
Okay, thank you.
Jeff.
Sorry, Lois, is it likely that as we go forward with the vaccination, it'll just be these max vac centres or vaccination centres that will be doing it while the primary care get back to normal? And what's likely to happen if there's further boosters required in the autumn? Is that likely to be done by these centres? Do we know?
I don't think we know at the moment. I think primary care's basic view is that if this is their work, contract it properly, give them surety. So for conversation with the flu, they know that the flu is theirs year on year in. So they know that their accountants have done their income and cash flows, and they have also got staff, and they're rotated in order to make sure that demand is met. But, I mean, and it's completely understandable because we are in year one of this. Should NHSE decide that this is the business of primary care and have surety of the fact that it's ongoing, primary care will do what primary care does best, which is make it happen. I imagine it will come down to money at some point. The way that the GPs are paid and the way that the mass vac sites paid are very different. And one of them will end up being more cost effective than the other, I guess, when somebody does the math. And I imagine a pragmatic decision will be made then. I think talking medical legally, and depending on reactions to AZ and any other booster that comes down the track or any other vaccine that comes down the track, the ability to be able to look in the patient notes will be needed. So if it isn't going to be done in primary care, then there does need to be some kind of access to patient notes.
Okay, thank you.
Lovely. Thank you, Lois. Any other questions for Lois on this paper? Nice and clear. Thank you very much. And please extend our thanks also to the relevant practices that you were talking about. Thank you. So we move on then to the next item, number 8, which is Primary Care Delegated Commissioning Finance Report. Jane.
Yeah, thank you, Chair. So the included in your pack is the finance report up to the end of February. We have subsequently closed month 12, so I'll comment about both of them. So effectively, the report that you've got in your pack shows the continuation of the trend that we've seen so far. It's been a bit of a strange year because the first half of the year, you'll remember, was on a kind of a central reimbursement basis. So we almost started again in month 6. The tables show that for that kind of 6 months period, the primary care delegated budget actually overspent up to the end of month 11, continued just on trend for month 12. So ending up just shy of, well, round about 800,000, just over for the year, overspent. However, we knew that this was going to be the case, and as in previous years, we set aside money within our programme budget to help offset those anticipated underfunding within the primary care delegated. And you can see the second table shows where we'd got other budgets relating to primary care, but significantly where we'd set aside some primary care contingency to offset. It's slightly over offset this year, but you'll remember that governing body did make some further payments to primary care at the end of the year. So so pretty much ended up on track overall for the year within the overall CCG's budgets, which have come in as a break-even position. So happy to take any questions if there are any.
Thank you, Jane. Any questions for Jane? Jeff?
What's the position? Well, are we going to have a problem in 21-22?
Yeah, so thank you. And
these are quite big fluctuations, even though you've managed to balance it out.
Yeah, so I should have mentioned that. So thank you. Segue nicely into the work that we're doing at the moment on the 21-22 budget. So we have been given a kind of we've been given funding allocations for the first half of the year that we've just started. Discussions are still ongoing about the second half of the year, but it's pretty much a rollover of the current situation. So effectively, the problems that we've got in terms of underfunding of the delegated budget continue into the new year. And indeed, so what's happened in the new year budget is we've been given an amount of sort of inflation growth and a very prescribed uplifts, but effectively, because our budget is already over committed, it just compounds the problem because we've got inflation on the original allocation and we've got to inflate the total spend. So we do get a little bit more of a problem, and we're having to continue to carve out a gap in the programme budgets to fund that. So it's more of the same, Jeff. Thank you.
Any other question for Jane? Thank you. Just one question from me, because I think I'm not necessarily seeing the figures. The prescribing budget seems to be underspent from a previous paper, and yet we seem to be implying that overall it's contributing to the overspend. So I'm a little bit confused on that.
So yeah, I'm a little bit confused on that, Linda. So I will clarify that for the minutes. Prescribing has been a very strange year. Again, we ended up with a kind of top up partway through the year, which brought everything back down to zero. And so we haven't had prescribing budgets in the normal way where we've done lots of interaction with practices, etc. But I will clarify what the year-end position is so that we can put it into the minutes.
Thank you very much. Okay, well, thank you, and well done for the balancing the books for this year at least. Thank you. And on to the next item, number 9, which is PPG update.
Hayley can't come until 3, so she's asked, can that be deferred until 3 when she can leave another meeting and do that one? So if you're happy to skip that and come back to it.
Yes. Okay, so thank you. So the next item, number 10, is the virtual meeting, which was confirming a decision we made on the Stanton surgery extension. Does anybody want to say anything about that, or you're happy that we confirm the virtual minutes? Lovely. Thank you very much. And so I've got item number 11, which is Primary Medical Care and Guidance Manual version 3. Is this back to Lois?
Oh, luckily it's Stuart.
Oh,
No.
Stuart, beg your pardon.
No, this is me. Thank you, Linda. So, this paper is written by one of my colleagues, Kathleen, but I'm presenting today. So I take the paper as read, but just to give you some context around this, some members of the committee might remember a few years ago, I tabled a paper about the Quality Guidance Manual per se. So the Primary Medical Care Policy and Guidance Manual is a weighty tome published by NHS England and Improvement, and basically covers all the areas to do with GP contract management and monitoring that we use as our Bible, I guess, within the primary care team. So it covers a whole wealth of things through from, list closures, branch closures, mergers, incorporation, procurement, and whatnot. So whenever we bring anything to this committee in terms of, asking you to approve a contractual change, the process that we follow will be based on this manual, and obviously we will always quote the relevant section to you. Every year the manual is updated or refreshed to take account of any latest government policy changes, regulatory changes, and so on. So quite a big refresh was done last year, and the refresh manual was published only this February. There was a delay because of COVID. So what this paper sets out to do is just to give you a flavour of the changes that have been made to the manual since the last edition. 1.1 at the top of the report, there is a link there through to the actual policy and guidance manual. I'm not obviously going to expect that you've all read it because it is 300-400 pages long. But if you were to look, or if you have looked, you will notice that throughout the latest version, it very helpfully highlights the changes in yellow, so it's quite easy to see what has been changed. So the changes under 2 are as they're listed. It's quite a lot to sort of get your head round, but that is a summary of all the changes that have been made, mostly amendment to sections, but also some new chapters and new sections that have been put into the report. So I think I will leave it there. I'm happy to take questions, or if anyone wants me to expand on any of the changes that have been made and are listed there, I'm happy to. But just to emphasise that I have at the end of the report that obviously this is only a guidance manual. Whenever we're doing anything contractual, it is the legislation that trumps the guidance. So there are many references within the guidance to the legislation and direction, but it will always be, the contract itself, the regulations that underpin the contract that will trump here, and we must make sure that we conform with those. Thank you.
Thank you very much, Stuart. Any questions for Stuart on the tome? We're all perfectly clear with the paper, and I'm sure that at the relevant time, in the relevant way, you will update us on the relevant changes for any contractual decisions that we need to make.
Of course, yes, yes.
Yeah, lovely. Okay, thank you very much. I must admit I was a bit overwhelmed by the link and the number of pages. I decided that others were better to digest that than I. Okay, if there's no other questions, thank you for the paper, and we'll move on to number 12, which is the contractual update.
Yes, that's me again.
Thank
yes,
you.
Thank you. So this is a kind of standard report that we're popping into the agenda of each PCC meeting, just to give you an idea or a summary of all the sort of contractual changes, issues that have arisen since you last met. We just thought it'd be helpful to give you a summary. Obviously, as you're probably aware, the NHS England primary care team covers the whole of the Suffolk and North East Essex STP. So for the sake of efficiency, we put all the contractual changes into the one report. So this is actually tabled at this meeting, the Ipswich and East and the North East Essex meeting. But just to clarify, in terms of West Suffolk, there's only two things on there that relate to West Suffolk at the moment, and that is the branch closure for Unity Healthcare. So just to update you that those premises did actually close on the 31st of March following your approval at the meeting in February. And under super partnership, obviously Suffolk Primary Care, there are one or two practices in West Suffolk CCG area that are part of that super partnership, and the finalised contract variation agreement to bring all those partners together are being signed as we speak. In fact, I'd say we were 95% of the way there. And then just for this report, and since we're not far past the 1st of April, I thought it'd be helpful to put in there just a summary of all the GP contract changes that became effective from the 1st of April. So, I mean, a lot of these were mentioned previously because it was a kind of a 2 or 3 year GP contract agreement, but some of the items didn't actually become effective until the 1st of April. So I've listed them there. So they're basically bundled up under changes to vaccination immunisation services, changes to QOF, changes to the primary care network, enhanced service, extended access, cervical screening, the digital offer, and then I just thought it'd be helpful to let you know what the global sum payment per patient will be this year. So again, I'll leave it there, but as always, happy to take any questions or to expand on anything that I've mentioned.
Thank you, Stuart. Do we have any questions for Stuart on this paper? None at all. Or the only question I would ask is around that super partnership, and whether that has any effect on the alliance working or the locality working, or whether it's, has any implications for the people of West Suffolk.
It depends what is being implemented, what the focus is, I suppose, what is being discussed, because the super partnership, what that is in a sense, it essentially means is that the partners of each of the practices, I think there's 12 practices in the super partnership, have come together to form one super partnership, but underneath the individual GP contract remain individual GP contracts. Okay. So if a practice wishes to merge with another practice, they can do. If an individual practice wants to close a branch, they can go through due process. The only change is that when the commissioner receives an application to close a branch or close a list or merge with a practice, we obviously have to have the agreement of the partners to to continue that process. So in the case of a practice that's within the super partnership, that agreement had to come from all the partners, even though we might only be talking about one particular practice. So it's an interesting question about the alliance working, but I guess the individual, because Suffolk Primary Care is actually spread across the whole of Suffolk, each practice will be in different alliances. So I guess, I don't know if Lois wants to come in here, I'm assuming that it's still a very practice-based thing in terms of those relationships with other bodies, but there is an overarching partnership agreement that sits above all those practices.
Okay, no, that's very clear. Thank you.
In terms of the two that are in the West, they're both in Forest, and they both act in the Forest PCN space and in their locality, as well as looking to Suffolk Primary Care to give them kind of overarching policy direction. I mean, so an example of where this gets great sort of traction with practices is when the CQC knocks at the door, the CQC team answers it and gives them a duplicate set of policies, procedures for all 12 or 13 practices. So they can go through them all again. Obviously, they have to make sure that they're embedded within that practice, but actually they have commonality of process, commonality of back office function, and those lead to sort of efficiencies and certainty. Certainly, they can have dedicated teams to pick off different elements, which definitely is a huge advantage for a smaller practice who struggle to cover everything at times.
Mm-hmm. Okay, thank you very much indeed. That's clear, and there's no other questions that I can see popping up. So very clear papers, which takes us really to the last item, which was going back to the PPG update. We are still 15 minutes away from 3 o'clock. The paper is fairly short and quite clear. Does what's your feeling, Lois, on
Yeah, I can
forward?
I can read it. I can read it out to you. So I'm assuming this was on the forward planner that we asked for it, or somebody else. Yeah. Yes. So this is obviously in response to that, and presumably the question was, what have they been? What is it, and what have they been up to? So I mean, the background pretty much sets out the story so far.
Yeah.
It really hasn't told you very much about, well, I suppose it's telling you about the network, but it's not really, hasn't really discussed many of the bits and pieces that you might have expected to see, that the CCG gave a grant to each of the PPGs of £1,000 each that they could access in order to take forward PPG work. Not all of them have done so yet, but I think we've rolled the money over again, such as it is. It probably, whether it's worth inviting her back to give a little bit of local flavour on, which of the practices, if she had a table that could add, who's active, who's non-active, who also goes to localities. I think the paper could be expanded somewhat.
Lois, I think that would be certainly helpful. My comments. Yes, and very helpful. That's really just saying they've had 2 meetings, that they've got one of their members has offered to chair on a rolling basis, and I think they're going to share it around, but there's actually no detail of what happened within the meetings and what's happening to support those that haven't yet engaged in the network, and why, and what else they can do to support them. So I think the action might be to ask for a second paper just to update on the things that you've outlined, and just to give a flavour of the activity within that, and also perhaps how it's supporting patients, and how they're linking in with perhaps the community engagement group and the locality engagement activities.
And how they've supported during COVID, because I know a lot of them have been absolute linchpins in terms of helping their practices, with volunteers. So I think, there's
some more rich data to come out of that, isn't there? I think. Lois, are you happy to have that conversation with Hayley?
Yes.
Thank you very much. Okay, does anybody else have any comments or questions on the PPG paper apart from that? No? Okay, lovely. Thank you very much. Well, that's the next meeting would be the 23rd of June. And Jo, just for the minutes, are there any questions from the public?
No, I haven't received any questions, no.
No, I haven't either. Has anybody else from the public to bring to this meeting? Okay, well, thank you very much. I think we'll close this meeting.